So I'm supposed to give two talks. The first is on the primary treatment of Hodgkin lymphoma, and this is mainly the result of the German Hodgkin study group, which I founded in 1978, but I will allude also on other study groups in Europe and in the United States. So I start with the management of early, intermediate, and advanced Hodgkin lymphoma, and I will continue with the systemic anaplastic large cell lymphoma, current status and further optimization. So we start with the early and intermediate stages of Hodgkin lymphoma, and then we'll go a little bit in the PET and early stages, perspective, and then we summarize, and we come to the advanced stages. So the early favorable stages are the clinical stage 1 and 2 without risk factors. And you see the risk factors are down here: large mediastinal mass, extranodal disease, high sedimentation rate, and 3 or more areas. The early unfavorable or intermediate stages are the stage 1 and 2 with risk factors, even the B stages, and the advanced stages are 3 and 4 stage and selected clinical stage 2B. And this is mainly with more than 3 areas or extranodal disease or a very large mediastinal mass. So if we go to the early stages, we have published this study in the New England Journal, and this study compared 2 versus 4 ABVD and 20 versus 30 gray involved field radiation. And we found out with a very high progression-free survival and overall survival rate of about 97% that there was no difference for progression-free survival or overall survival between 2 or 4 ABVD or 20 or 30 gray. The next slide shows you the question that we asked in the German Hodgkin study group. Do we need dacarbazine and do we need bleomycin? And do we need both of them? So we made a study, ABVD versus ABV versus ABD versus AV. And we gave 30 gray involved field because we had changed too much in the chemotherapy region. And when you look at the acute toxicity for ABVD, ABD, ABV, and AV, you see that the most leukopenia is with ABVD and ABV. That means bleomycin seems to have some effect in the ABVD and ABV. And you see that most of the ABD and ABVD is rather similar. There's not a big difference. And any grade 3 and 4 toxicity is the highest in ABVD and in ABV, but much less in ABD. So we looked at the progression-free survival for all patients. And here you see that the 4 curves are depart. The best one is ABVD, then comes ABD, and this is ABV, and this is AV. This is what we expected. Overall survival, there is no difference because you can salvage all 4 regimens. If you then look at the difference between ABVD and AVD, which we continued, and we have about 600 patients in ABVD and in AVD, there is only a difference of 3.9%. But we, in our protocol, we said we should have an inferiority margin, a non-inferiority margin of 1.72, but we reached only 1.5. So our statistical people said the non-inferiority cannot be concluded. That means they said ABVD is better than ABD if we leave out the bleomycin. But if you, for the clinician, only 4 out of 100 Hodgkin lymphoma patients have a benefit if you add bleomycin. And this is what you can decide when you have a patient, for instance, a smoker, an older male patient who has already in COPD, then you can leave out bleomycin without any harm for the patient. If you look now at the survival rate, then you see nearly no difference. This is not statistically different. Then you see that nearly all of them can be salvaged, even the AB and the ABV. This is a result of the HD10 trial. And then we continued and asked the question, if we use the PET, unfortunately you don't have many PET institutes in Ukraine, but in Germany we are allowed to use the PET in the early phase of our study. So if you have 2 ABVD, PET negative or positive, we give 20 gray in both fields, and this is our standard. 2 ABVD plus 20 gray in both fields. In the experimental arm, we asked the question, do we really need a radiotherapy if you continue if you have a negative PET? And if the PET is negative in our HD16 trial, we don't give radiation, and we have only the radiation in the PET-positive patients after 2 ABVD. And this is the ongoing study. We have about 800 patients already in this study. If you ask now, what do we do in the unfavorable or intermediate stages? Here is normally 4 ABVD plus 30 gray, and this is, I think, the general standard globally. We made a study, 4 ABVD 30 gray, 4 ABVD 20 gray, 4 BCOP 30 gray, and 4 BCOP 20 gray. And you see that the 4 ABVD plus 20 gray is inferior, significantly inferior to 4 ABVD plus 30 gray. So if you use ABVD, you have to give 30 gray and not 20 gray. If you use BCOP, 20 gray is good enough, but BCOP is not much better than ABVD. So we have to ask the question, since we have still intensity of chemotherapy, and we used 2 escalated BCOP, 2 ABVD, and compared it with 4 ABVD plus 30 gray. And if you look at this curve, the 2 plus 2 is significantly better than 4 ABVD. And this is now the 2 escalated BCOP plus 2 ABVD is our gold standard. And in the next study, we asked the question again, if we have a PET negativity after 2 escalated BCOP, our new standard plus 2 ABVD, do we need radiation? And we compare PET negative patients, 30 gray in both fields versus no radiation. In the PET positive, we compare involved fields versus involved nodal irradiation. And this study is ongoing. There are about 700 patients already recruited. So what is PET in early stages? And unfortunately, the PET results are not so convincing and so robust that we can say, we can conclude already that PET negativity does not need radiation. There is a study from the UK, and this is a reference study. They used 3 ABVD, and if the PET was negative, they randomized 30 gray versus no further treatment, no radiation. In the PET positive, they gave a 4th cycle and added 30 gray radiation. And they had 209 patients PET negative and gave them radiation, and 211 PET negative that did not get radiation. And you see here that 20 patients had a progression when they did not give radiation. 8 in the PET negative with radiation. 7 died here, only 1 died here. We think that the answer is not yet given in this study because there are too many progressions if they don't give radiation, and then you have to give high-dose therapy, and this is a burden for the patient psychologically and from the toxicity. Therefore, I think this Redford concluded that you don't need radiation in PET-negative patients. So this is the second study on that question, and the ERTC did another study, 2 ABVD, if PET negative, no radiation. If PET is positive, they give 2 BICOP escalated and then 30 gray radiation in the low risk group. In the intermediate group, 2 ABVD, PET negative, 4 ABVD. That means altogether 6 ABVD. If PET is positive, 2 BICOP escalated and involved field. When they had about 700 patients in this study, the data monitoring committee said, please stop the study in the negative group for early stages and intermediate stages, because they had in the experimental arm where they had PET negative but no radiation, 9 relapses, and only 1 in the standard arm where they gave radiation. And in the intermediate group, they had 15 relapses, and here in the standard arm, only 7. So they concluded that it is not right in the PET-negative patients to exclude radiation. In our opinion, it is too early to conclude this and give this conclusion, because similar numbers of events but opposite conclusions in the Redford and the ERTC studies. The conclusions based on rather few events and too short follow-up. This means 3 and 2 years. Both trials stopped, as we think, too early, and we need more follow-up for sound conclusions. And it is definitely important to have a central PET to review the data of the early PET results. So our conclusion is that we don't know the answer yet whether a PET is negative after 2 ABVD, whether we can stop or should give radiation. And our HG16 trial will add more information, and possibly in 2 or 3 years we will know more about PET in the early and intermediate stages. So the perspectives, where do we go from here? And here we have new antibodies and molecules for clinical trials in early and in advanced stages of Hodgkin lymphoma. We have the brentuximab vedotin, Adcetris, anti-CD30 antibody. We have the AFM13, a bispecific CD30 antibody, ofatumumab and rituximab, everolimus, an mTOR inhibitor, and ruxolitinib, a JAK inhibitor. And then we have the abrutinib that has highly effective responses in non-Hodgkin lymphomas, and we have the nivolumab anti-PD-1 monoclonal antibody. So what can we use for the future? And I think the forerunner is brentuximab vedotin, the antibody against CD30, with a potent antitubulin agent, monomethyl auristatin, and protease cleavable linker, an anti-CD30 monoclonal antibody. And this construct is very effective even in advanced relapsed and refractory Hodgkin lymphoma, and we come back to this later. The antibody construct is taken to the receptor of the CD30 tumor cells, is then internalized, and in the lysosome the linker is released and the active drug is doing its job on the microtubule, and the mitosis is inhibited, and with this the tumor cell is destroyed. If the tumor cell in Hodgkin lymphoma is destroyed, all the reactive tissue around this tumor cell is reduced and destroyed. So the highly effective response of brentuximab vedotin is because the tumor cell that speaks to the surrounding cell is destroyed, and therefore we have this fantastic results with this antibody. What shall we do in the future in the early stages? We will reduce chemotherapy by giving 4 brentuximab vedotin with 20 gray involved or only on the site of the tumor radiotherapy. Or the other possibility is the strategy B, replacing radiotherapy. We give 2 ABD and then 4 brentuximab vedotin and leave out the radiotherapy. These plans are in the German Hodgkin study group. There are other studies around the world that I don't want to allude now in the short time, but you will hear more about that at ASH in December in the United States. So the summary for the early and intermediate stages is 2 ABVD plus 20 gray involved fields is now the standard globally, and more chemotherapy is not better. In the intermediate stages, we give 2 as the BCOP 2 ABVD, or you can get 4 ABVD plus 30 gray, not 20 gray, and chemotherapy is not better. Some studies have shown that. So a combined modality treatment, radio and chemotherapy is standard of care in these stages. The role of PET is not yet established, and involved field only in stage 1A is a standard of care in nodular lymphocyte predominant Hodgkin lymphoma, and new approaches for that stage are underway. And we need new less toxic regimen, and here brentuximab vedotin is a forerunner for a combination of chemotherapy with these new drugs. So this was our International Hodgkin Symposium in Cologne, and many of you have been there, and in 2 years we have our next meeting in Cologne, and I invite you already for this meeting. So what do we do in the advanced stages, and what are the perspectives? So there is the UK and the United States, Canada philosophy giving ABVD or Stanford 5, but Stanford 5 is nearly out. Then you have 71% progression-free survival after 3 years, and then you continue. What you can do then is escalate ABVD, because 71% means that you have 90%, 29% failure rate, and these patients need hydrotherapy and stem cell support. And there are new studies ongoing with PET-guided with ABVD and brentuximab. I come back to this later. In Europe, most of the big groups and centers now use escalated BCOP as the frontline therapy, and they come up to 91% progression-free survival and have only 9% failure rate, not 29%. And further de-escalation is a strategy of the future. PET-guided studies, our HD80 trial, and new studies with brentuximab adding this to the BCOP, and we come back to this later. So which studies are ongoing? And there are 2 strategies. The philosophy of the UK and USA as late intensification. Start with ABVD times 2. If PET is negative, continue either with ABD or ABVD. If PET is positive, go to escalated BCOP or BCOP 14. If then the PET is positive, go to radiation or salvage therapy. In the US SWOG study that I showed you, 2 ABVD. If PET is negative, continue with ABVD. If PET is positive, in about 18%, here 82% are PET negative. In this 18 to 20% continue with escalated PCOP, or in HIV positive patients give PCOP baseline, coming up to 66 to 71%. In Italy, the Bologna group starts off with 2 ABVD. They include the 2B stages, what we don't do. And if PET is negative, continue with ABVD. If PET is positive, they go directly after 2 ABVD to salvage therapy, either EGF or DHAP or ICE. We come back to this later. And there is another detailed study of Galamini. They start off with 2 ABVD. If PET is negative, they go to ABVD and randomize radiation or no radiation if the PET-4/6 is negative. If PET is positive, they do the same as we do in our HD18 trial, escalated PCOP times 4, or rituximab escalated PCOP, and if negative, then they do PET-CT and no radiation. They come up to about 66 to 76% in the late intensification, giving ABVD first and then high-dose therapy in about 30 to 40% of the patients. And I think this is too much. And if you don't have, like in Ukraine, too many centers that can do high-dose therapy and autologous stem cell support, then I think you should do that. What we have done, early intensification, and Irina has done a fantastic study in Ukraine, and I congratulate to the results of this study that were shown in the Lugano advanced stages, escalated PCOP first, and if then the PET is negative, no radiation. If the PET is positive, give 30 gray radiation. We came up here to 10% radiation only after 6 escalated PCOP, and 6 escalated PCOP was better than 8 PCOP escalated or 8 PCOP baseline. What we found out is progression-free survival after 5 years is 89.3%, that means 90% better than 66 or 76, about 25 to 30% better with the early intensification, and only 9 to 10% need high-dose therapy. So I think this is the philosophy in Europe and possibly also in Ukraine and in Russia. But we all know that PCOP is very expensive and very toxic. Therefore, we have to balance efficacy with morbidity. If you look at the profile of PCOP escalated toxicity, then you have the organ toxicity, heart and lung, the second neoplasia. You have the polyneuropathy, you have AML, MDS, and in about 70 to 80% infertility in the young boys and hypogonadism in the female. And you have the tumor-related mortality of about 0.5 to 0.8%. And for the long run, and these patients are young and possibly live for another 40 years, you have the quality of life reduction, fatigue, cognitive deficit, and we have to take care of these patients even after 20 years. So what we intend to do in Germany, we have further de-escalation, PET-guided, and then we want to add brentuximab to the PCOP and detoxify the PCOP. And we come back to this later. So there are studies ongoing with the early intensification. This is the LISA, the French study, 2 PCOP escalated as well in the standard arm, if positive or negative, and then they give PCOP, 6 PCOP escalated like we did in the HD15 study. If it is positive, they give salvage. And in the experimental arm, they give 2 escalated PCOP. If negative, they continue with escalated PCOP, and they go to ABVD to find out whether we can release these patients from escalated PCOP and go to ABVD. It's a very important study, and enrollment is much faster than expected, and in about 2-3 years we will have an answer whether we can, after 2 PCOP escalated negative, we PET negative, we can give ABVD. The German study, and we have concluded this study with 2,000 patients, we give 2 escalated PCOP. If it's positive, after 2 escalated PCOP, we continue with another 4 escalated PCOP. If it's negative, we give only 2 more PCOP escalated or 4 escalated. That means 6 versus 4 escalated PCOP, and we will see which group is better. So the enrollment has recently finished with 2,104 patients, and about 2 to 3 years we will know the answer how much escalated PCOP we really have to give. And I explained already this year, brentuximab vedotin on the market. Can we reduce morbidity while maintaining efficacy by adding brentuximab vedotin? There are data from phase 2 studies where the overall response is 75% and the complete remission rate in far advanced relapsed and refractory patients is altogether 34%. And these patients had not reacted anymore to chemotherapy and radiotherapy. The only important sensory neuropathy was 8%, and this might limit the dosage of brentuximab vedotin when you had a lot of Velbam and vincristine. There is a phase 3 study ongoing, the ECHELON-1, and this is a global study undertaken by Takeda in advanced stages, and they use ABVD versus AVD plus Adcetris or brentuximab vedotin, that's the same. And then if you have a PET negativity or 1 to 4 Deauville score, then you continue with AVD or ABVD. If you have a PET positivity, Deauville score 5, you can continue with ABVD or give salvage therapy. This study is ongoing and recruiting in this industry-sponsored trial. This trial expects 75% with ABVD and 82%, only 7% more progression-free survival with ABVA. So this is relevant for the Takeda to get the permission to put it on the market. So what can we do with PCOP to de-escalate PCOP? We know that the feasibility is hematotoxicity in the majority of patients. That is the only problem, and you can do it only in centers where you have experience with leukemia and lymphoma treatment. The early mortality and severe infections due to long steroid dosage during cytopenia, and then the AML-MDS, mainly procarbazine, etoposide, cyclophosphamide, and the infertility is mainly procarbazine, and the organ toxicity is vincristine. So what we have done, we have detoxified the PCOP escalated and have already done a study with a rather moderately reduced drug regime breakup, where we leave out the vincristine and we leave out the bleomycin. And we give in the breakup the more important drug regimen that we possibly will use in the future. We leave out vincristine, leave out procarbazine, and leave out prednisone. And we add brentuximab, we add dacarbazine instead of procarbazine, and add dexamethasone instead of prednisone. So we have done a study with 104 patients, breakup versus breakup, and what came out is that the primary endpoint was PET negativity after 6 courses. And with the BRCA, we have only 5% still PET positive. In the BCOP study, it was 7%. In the BRCA study, it was 15%. That means BRCA possibly will be the forerunner for the future. If you look at the BRCA toxicity, you will see only the hematological toxicity is as big as in the BCOP regimen in HD18. But the organ toxicity is much less, only that means 3% in the BRCA regimen and in 14.3% if you give BCOP escalate. So if you look at the BRCA and the BRCA together, you have a nervous system toxicity grade 3, only 1%. And in the HD18, this is the BCOP escalated, you have 5%. That means in the entire cohort, you have 30% lower toxicity, whereas in the AVDA study, the global study, has 73% because of the Velbam that is given in the AVDA. So the new study in Germany, the HD21, will be 2 BCOP escalated, there is 2 BRCA, and then PET, 4 BCOP escalated and 4 BRCA, and I hope that the Ukraine can participate in this new study because we have the same efficacy but a much lower toxicity, and even the infertility and the leukemia rate seems to be lower with the BRCA compared with BCOP. The primary objectives for the future is non-inferiority of BRCA versus BCOP and superiority of BRCA regarding treatment-related morbidity and end of treatment, better results. Tumor response, less infertility, less secondary malignancy, and therapy adherence. The patients having had BRCA have said it is much better and they had not too many toxicities. Quality of life is a very important long-term aspect that we have to take into account. This is the toxicity of BRCA, this is the toxicity of BCOP escalated. And we hope that we come up to 91% progression-free survival, and if you compare it to the AVDA study, the Echelon, it's 82, or AVD 75%. So the challenges is tolerability, efficacy, and possibly you can participate in Ukraine in the study. And I think we have to ask Takeda whether they can help us to supply this unfortunately very expensive drug. So in the future, it is Echelon 1 ABVD in the ABVD area, and here it is the HD18 trial, the LISA trial with the PET-guided detoxification, and here with the targeted BCOP or BRCA HD21 comparing BCOP versus BRCA. So coming to the anaplastic large cell lymphoma, this is an aggressive lymphoma from the non-Hodgkin lymphoma area, like the diffuse large cell, mantle cell, peripheral T cell, and here is the anaplastic large cell lymphoma. This is the group of patients that we have to take care of because the primary treatment is not sufficient yet. The cutaneous T cell lymphoma is only very few and has rather good prognosis. The LCL is the cutaneous LCL, and the systemic anaplastic large cell lymphoma, and here we have the ALK positive. ALK is a tumor marker that is very important to determine, to make the diagnosis very certain, and the ALK negative. Patients with LCL present with aggressive, often advanced disease, primarily involving nodes and venous areas. Advanced stages present in 65% in ALK positive and in 58% in ALK negative anaplastic large cell lymphoma. Extranodal involvement is in about 60% of these patients. This is a CD30 positivity and about 100% of these ALCLs are CD30 positive, and half of them are ALK. This is the marker, and a very important cytogenetic marker, T25 translocation, that gives this marker positivity, and you can decide is it ALK positive, CD30 positive, ALK negative, or CD30 negative. Because the ALK positive anaplastic large cell lymphomas have a better prognosis and progression-free survival than the ALK negative if you use the standard treatment, and this is mostly CHOP-like regimen. So the ALK, the systemic anaplastic large cell lymphoma presents in 55% with ALK expression, and the cutaneous, the ALK is absent. CD30 is present in both the cutaneous and the systemic, and the clinical presentation is here: peripheral abdominal lymph nodes, B symptoms, and especially high fever, and here it is more in the skin. Site of involvement, lymph node, external side, and here is trunk, face, and extremities. So what do we do? For treatment of primary, we give CHOP, plus minus autologous bone marrow or hyper-CVAX or more aggressive treatment, but only 40 to 50% have a complete remission, and 40 to 60% relapse, and 30% are with primary treatment refractory. So this is unmet need, what we should do. And the second line treatment is limited, high efficacy option, salvage regimen is not very good because 50% relapse, and after 1 year the overall survival is rather poor, 1.5. And the third line is little consensus on optimal therapy, and there we have to do something. What is on the market for the relapsing anaplastic large cell lymphoma and the PTCL, lenalidomide, and different other pentostatin, romidepsin, pralatrexate. But if you look at the CR rate, it is 10 to about 20%, and most of these patients very quickly relapse. Therefore, there is unmet need for these aggressive patients, a tumor, and we have to do something. And in spite of the potential complete responses to frontline treatment, ALCL is associated with high mortality rates and is refractory to frontline treatment in up to 30 to 40%. Therefore, novel targeted agents are necessary to improve patient therapeutic responses and limit toxicity, and could lead to better long-term outcomes. Okay, this was my first part, and I hope you could understand me, and if you have questions, I'm happy to answer your questions.
Okay, thank you very much. Thank you for the first part of the lecture. И, пожалуйста, если есть вопросы, пожалуйста, задавайте вопросы. Professor Dill, may I ask you to speak a little bit closer?